Well, good afternoon, everyone. It's a pleasure to be here in this wonderful event. Thought we would start off just doing some brief introductions, and then we'll get started. My name is Mike Sokol. I am your moderator today. I'm a preventive medicine physician. I've held a number of corporate roles in my prior careers and currently work as a population health consultant. And with that, I'll turn it over to Mike, and then Neal, and then Trudy.
Good afternoon. Mike Russo. I am filling in for my colleague Joe Naris at Memorial Sloan Kettering. I am a PA by training and the Senior Director of Peri-Operative and Procedural Advanced Practice at Sloan Kettering.
Hello, Neal Mills, Chief Medical Officer for EHE Health.
I'm Trudy McKanna. I am a genetic counselor by training and the Senior Director of Medical Affairs at GRAIL, the multi-cancer early detection company.
Great. Well, we've got a great panel today, so let's kick off with the first question. And it concerns early detection and bending the cost curve. So everyone agrees that early detection saves lives, but screening, new technologies, follow-up care can also add costs quickly. And we've got obviously a lot of folks in the audience that are concerned about improving quality of care, but controlling costs as well. So where does early detection truly bend the cost curve, and where does it risk expanding it? So, Neal, I'm going to start with you, and then Trudy, if you could follow up.
Sure, I agree with you that it's ideal to catch it upstream. The studies and screenings that are aligned with the USPTF typically help you find those, and they're typically cheaper than some of the newer technologies emerging. But there is a lot of desire, especially amongst executives and those with discretionary income, to get access to these new technologies that can find cancers even earlier, but there is a cost associated with that. And so I think the general guidance is in alignment with the triple aim, maybe the quadruple aim, but I see these other technologies rapidly evolving and being very competitively priced.
And I think we are one of those new technologies that is rapidly developing. And so multi-cancer early detection is a way that we can ideally hope to bend that cancer curve by detecting cancer instead of after it presents with symptoms, which is very often stage 4 metastatic cancer. That is also very expensive to treat, about 3 times more expensive to treat than earlier stage cancer. MCED has the possibility of detecting cancer in asymptomatic people. And we actually just published a study a couple weeks ago, or presented a study that showed a 26% reduction in stage 4 cancer diagnoses of the 12 deadliest cancers. And I think to get to your question too about how could it expand the cost curve, you want to make sure that when you're doing these screenings, it is for deadly cancers where detecting them early can really make a difference. What we don't want to do is overdiagnose indolent cancers like a thyroid cancer and encapsulated prostate cancer, where that's just going to cause more cost to the healthcare system, but isn't going to change the outcome. So it's really important to think about that when you're thinking about adding those new technologies, is what are we screening for and what is the efficacy of screening for those cancers?
Yeah, thanks, Trudy. So the next question revolves around provider networks. So when an employee receives a cancer diagnosis, what should employers be thinking about in terms of what they get from the provider network, and how much do outcomes vary between community oncology and, let's say, specialized cancer treatment? So Mike, do you want to kick that off?
Yeah, I think the biggest thing that employers should want for their employees is care navigation. When someone gets that cancer diagnosis, their world has been turned upside down. And not everyone works in medicine. You shouldn't have to have a medical degree to figure out what the next step is. So the system providing that level of navigation, where to go, where to be, what tests to get, and the order they should go in. All of that matters, especially with downstream costs. Getting the wrong test earlier can often lead to more expensive testing, delays in diagnoses down the road. The other part, like going to a specialized cancer center, something like Memorial Sloan Kettering, you are getting a level of specialized cancer that you just don't get at multi-specialty institutions. Where you may go see a surgical oncologist, when you come to Sloan, you see a hepatobiliary specialist. All they do all day, every day, is liver cancer, gallbladder cancer, pancreatic cancer. You go see a surgical oncologist, they may go from the melanoma treatment to liver treatment, right? Surgery to surgery. So that level of specialty and that level of expertise, and it shows in the outcomes. I think the 5-year survival rate on one of the latest studies coming out of Sloan Kettering, 81% across all cancers, across all stages, compared to 73% in the rest of the country. So the results speak for themselves. And again, it's that navigation that gets you to the right person at the right time and that right specialist.
Thanks, Mike. Neal, did you want to add anything to that?
Yeah, I think my question to employers is how well are your vendors working together to support this care navigation and getting a timely referral into a specialist, supporting a second opinion? And so how are those decisions enabled and how is this facilitated? It can be a very confusing and bewildering time for patients that need to navigate during the time of their greatest need.
Right. So let's kind of stick with this topic a little bit about navigation. Employers are obviously looking at their data, want to look at their data to do data-driven outreach, preventive exams, guided navigation. How can employers use this information to guide people who are falling through the cracks, prompt action at the right time, and connect employees to the right care quickly? What have you seen work at scale? And again, kind of keeping the cost information in mind. And I'll throw this out to the whole panel.
You want to start, Trudy?
Trudy, do you want to start?
Yeah, coming from a company that really wants to change that cancer screening paradigm, I think we're looking at what has been successfully done for decades in the single cancer screening space, and how do we pull that into screening for more cancers? While single cancer screening is fantastic, but it only detects about 14% of cancer deaths are caused by cancers that we can screen for. So we really need to start applying some of the learnings from that. What makes a good test? What is the test performance we want to look like, and how can we pull that in without adding cost to the healthcare system?
I guess my question that we should all hopefully, as we navigate the hours it could take to get home with the parades and all the celebrations, do you as the employer have a vendor that provides comprehensive prevention program services, someone who owns the entire screening process and all of the USPTF aligned and recommended services? And if you don't, then what is your plan to get there for your employee population?
Mike?
I think on the employer side, I think one of the biggest things that folks can do is encouragement. Trudy and I were speaking before we came out here. It's one thing to have a partnership, with a single screening test. If nobody uses it, if they don't know it's available, it's not helping. You're not getting ahead of the cancer. You're not picking stuff up in an earlier stage, preventing later stage treatments and things like that. So I think from the employer side, I think the encouragement to use what you have, whatever it may be or whatever direction you go, encouraging folks to use it, I think is one of the biggest things.
So let's stick with this topic of navigation then. I think the employers might be interested in understanding more about what good navigation really looks like. So let's say once a risk is identified or someone's been diagnosed with the cancer, what would good navigation look like to ensure employees get high quality care, the right treatment, and again, trying to avoid waste, improve outcomes, look at the cause. We can go a little bit more in depth. And I would also add, there's so much we're hearing about navigation. There's independent navigators, there's health plans that are doing it, there's other solutions. I mean, any thoughts about your experiences about who might do it the best? So Trudy, do you want us to kick that off?
I think that a combined approach is probably the best, just like with anything. Thinking about care navigation, and you were just mentioning the importance of awareness and education. So that comes from who's offering this new test. Is it the employers? Is it employee benefit? Is it the provider? Being open to learning about these new technologies, to offering these new technologies, but then also for companies or physicians who've started to offer this testing, sharing what you've learned and building those centers of experience, those places where we can build from that and learn from that. I think that's a responsibility and an opportunity for both employers and physicians who find new opportunities for cancer screening. I would also add that any lab that's doing this kind of new technology also has a responsibility to provide some of that care navigation, because we don't want patients to fall through the cracks, and we want to be able to supplement what already exists. So things like patient advocates. Are you having trouble getting to your appointments? Some people don't know where to find those resources, but if they know, I can call the lab that I have, like the name of the lab that I have on my test report, and see if they can help. Can they talk to my provider? Can we get back to working with those centers of experience so that we can create more of a web of resources than individual little spots?
Mike?
Yeah, I think when we're talking about navigation, I think the biggest pieces are getting people to the right spot at the right time. It's not always the quickest. It's not always the person that can get you into tomorrow, but the person who can provide you with the best treatment. Our worry and some of what we see is folks going down the wrong path, potentially getting an initial treatment that has now precluded them from going into a clinical trial or being able to receive a different treatment because of the way the first one went. So a lot of the navigation piece, it's not speed, but accuracy. The right person at the right time when you need it, And it's very hard when folks, they get that diagnosis, their life's been turned upside down. Everyone wants an answer tomorrow, right? And it's difficult to give, and it's not something you want to rush into. There are so many unknown ramifications of going down the wrong path. So I think it's not just speed. You shouldn't have to wait forever, and I couldn't agree more. But tomorrow isn't always the right thing. So I think making sure that they're getting a comprehensive plan. It's not just the cancer care, the chemo or the surgery that goes into it. Finding a place that navigation helps with psychological care, care from the side effects of the treatments that folks are getting, and an understanding of everything that goes around it. And that's where specialized cancer centers and places like MSK really come in. If you need that psychological support and care, it's not necessarily a psychiatrist who deals with anxiety or generalized anxiety in the population. They understand the treatments that you've gotten, the effects of the medications. They work with cancer patients all day, every day. So it gets into a lot more on that navigation side than just the true cancer care, but the care of the whole person.
And Mike, just a quick follow-up. In terms of the people that are doing the navigation, does it need to be cancer specialists per se, or cancer nurses? Could it be general people that aren't necessarily specialists in cancer but could be guided through that, or what would be your recommendation?
It can be, but because of the level of complexity that a lot of these things go through, I think you're going to be better served by someone who lives in that cancer world every day. The ability to understand things that change sometimes on a weekly or monthly basis based on the level and the speed of research right now. That if it's something you do most of the time, there may be things that get missed along the way. If it's me, my family, I want someone who does this all day, every day, and lives in it.
No, it makes a lot of sense. And in terms of like the audience thinking about sort of the non-negotiables, those things that are an absolute must for the employers, things like targeted outreach, screening strategy. We talked about navigation. I'm sure people are thinking about second opinion, centers of excellence, outcomes tracking. What would, in your opinion, for the three of you, what are the non-negotiables to ensure better cancer treatment and to see better outcomes, and also thinking about bending that cost curve? Neal, did you want to start with that?
Yeah, I mean, sometimes you'll see the health plan following through with an accreditation, URAC and NCQA, but sometimes there's still a lingering worry that the screenings that could have been provided haven't been, or not as comprehensively. And that's when you might want to look at an organization like EHE that has excellent screening for all of the USPT recommended programs, because that's all that we do. And we are one of the pillars of primary care. And we refer into primary care, but also specialists. When our screening exams come back and they're abnormal, it's all that we do, because that part of primary care is broken. And so we built the infrastructure so that we could do it exceptionally well.
Right. Trudy, non-negotiables?
Thinking about the targeted populations, we think about cancer screening and single cancer screening, and not everybody gets their single cancer screen. If everybody did, it would actually increase the detection of cancers by double, probably just with prostate, breast, cervical, and colonoscopies. That's one thing that we need to make sure that these people know what their options are, that they are at risk, and that there are options for them. But we also need to think, and employers need to think, what else is out there besides just those single cancer screens? Because the more cancers we can detect earlier, the sooner we can get treatment, the sooner we can get them into systems like MSK.
I think off Trudy's point, the early detection of some of those most deadly cancers, I think, is a huge piece. The amount of cost associated with the finding of a cancer at stage 3, stage 4 is just tremendous. So it's the early screening, the early detection, utilizing the programs. Repeat what I had said before is that you can have every program as an employer and offer everything. If the employees don't know about it, if the employees don't follow through and take advantage of it, then you might as well not have it. So moving folks towards encouraging your employees to take advantage of these resources, making sure they know what's available and how to access it.
Right. Neal?
I don't think I have anything to add.
Kind of sums it up. I did have a follow-up though, because I think, Trudy, you talked a little bit about kind of the multi-cancer and the early detection. I think there's questions about the value of that, also the potential for overdiagnosis. So my question would be, with the emerging tools that we're seeing in multi-cancer early detection, how should the employers be thinking about balancing that clinical value with potentially false positives and even costs that could be associated with that?
Yeah, I think that's a great question, and really important for employers to be thinking about and asking themselves critically when any kind of new technology comes in. But I'll talk through maybe what we look at as what is essential criteria for a good multi-cancer early detection test. First pillar would be, does it detect the deadly cancers, and ideally unscreened cancers preferentially. If a lab is offering an MCED, they should be able to tell you, this is our detection rate for these cancers. And to your point, we don't want them to be detecting those indolent cancers. We want them to be detecting the pancreatic, the ovarian. We want it to have a high positive predictive value. If you get a positive test result, what is the likelihood you're going to go on and get a diagnosis of cancer? With mammograms, that's about 4%. We're used to that, we're comfortable with that. We want something high, 50%, 60%, so that there's an urgency sense to get that followed up. But also at a low false positive rate. You don't want to be sending a lot of people into the healthcare system unnecessarily. So that false positive rate should be less than 1%. It should be pretty low. You want it to be directed. When you get those results back, if there is a cancer signal detected, it should tell you where in the body you need to go follow up. Because if they don't, you're just sending that patient on a diagnostic odyssey that is not a good use of healthcare system dollars.
Neal, did you want to add anything to that?
Yeah, I'll tell you that we are asked nearly every day about GRAIL and others that we're going to be offering. They want that, especially for their executive track and perhaps their total populations. And they're trying to understand what that experience would look like. So there's a lot of curiosity in the market.
Yeah. And Mike, I had a follow-up for you, because I think you touched on this a little bit earlier when you were talking about sort of that comprehensive approach and the care navigation. Can we talk a little bit about sort of the non-clinical pieces? Like we always hear about social determinants of health, right? Whether people can actually get to the doctor, can they understand their instructions? Is someone helping them with nutrition or whatever? Can you talk a little bit about sort of those social determinants that play a part, and why that's so important as you're navigating through a cancer diagnosis?
Absolutely.
Yeah.
I think what people often forget is we focus, and for obvious reasons, just on the patient. It's that patient's whole world that's affected by cancer diagnosis. It's their children, it's their parents, it's caregivers, it's spouses, significant others. Everyone is affected by someone's diagnosis. And it's being able to help with everything, whether it's financial counseling, whether it's, as you mentioned, nutrition, right? Helping people heal after the diagnosis. What does a program look like after somebody's in remission? What does that survivorship piece look like? Are they going to be followed? There's everything that comes after cancer as well that needs to be considered. Many folks end up on hormone therapies. They need special screenings at certain intervals. There's a specific percentage of recurrence rates in specific areas. All of this stuff, so there's a tremendous amount of focus on just the treatment. But like you alluded to, there's so much more. The psychological effects, the financial effects, and having those resources and the people, again, who have navigated these problems with other folks, and it's their job to do so, is what places like MSK can offer.
So let me ask you too, because we've got a lot of largely employers in the room. Whose responsibility really is it then? From your opinion, should the employer be providing these resources? Is it the healthcare navigation vendor that they're using? Is it a combination? Who do you think would be ultimately?
I'm biased, but I think it's on the institution, right? Like, I wouldn't have an expectation personally of relying on my investment firm or my technology firm to be the one to guide me through my cancer care. Right? I'd want the folks who take care of cancer every day to be doing it. So, personally, I think the responsibility is on us at the institution level to provide appropriate navigation and whole person care, and that's where I think it lies.
Okay, great. Well, I see we have 18 seconds, so we're going to end just a few seconds early. It's really great to be with all of you. We hope this was informative and interesting, and hope you enjoy the rest of the day. Thank you for your attention. Appreciate it.